Good morning, everyone. Welcome to Pediatric Grand Round. We're not dressed up for Halloween. We look like this all the time.
The eyes of the patient, I think.
Yes, I'm always an alien. All right, today's speaker is Dr. Karina Miller. Dr. Karina Miller graduated from the College of Dentistry in Brazil in 2001 and completed her pediatric dentistry training at that time. She went on to join the Brazilian Army and worked for multiple years there prior to moving to Florida, where she completed her residency and fellowship training in 2012. She joined the Department of Periodontology and completed research, which was award-winning multiple times. In 2017, she relocated to Roanoke and worked as a hospital dentist and part of the craniofacial team. Please join me in welcoming Dr. Karina Miller.
Well, good morning, everyone. Good morning. I feel very at home seeing all these costumes here. That's part of being a pediatric provider. I love it. Dr. Dowick in University of Florida, he's probably retired. This way, cannot move. I'm sorry. He is the chair of the orofacial surgery. And you know that those guys, if you have any encounter with oral surgeons before, they are hardcore people, face trauma. You know, they're not very like that. And then he was giving us a lecture, and he said, well, the two best people in the world are veterinarians. Oh, he said three: the pediatricians, veterinarians, and people that work with seniors, because they can really see through the heart. They can see the person and read. And whoever can work with animals also has that tender heart. So I'm very proud to be a pediatric provider. Thanks for having me here, Dr. Parmeshwar. I'm really, really happy. I love to share what I've learned through the journey of my years. The way she said sounds very nice. It was very painful to get where I am right now, but it sounds a lot better on paper. So we're going to talk about pediatric oral health, early childhood caries, and its implications. That's my daughter. I have no relevant relationship, me or my family, with any of the products, unfortunately, that we're going to talk about. So the objectives of this lecture today, and pardon my English, okay? This is one weak point there's some foreign people here. It's so hard for me. And if I do say something that sounds weird, I really don't mean it, okay? So it's to explain the epidemiology of early childhood caries. We're going to discuss the etiology of ECC. I'm going to say ECC as a short for early childhood caries. That's the terminology that we use in dentistry. No longer we use baby bottle decay, rampant decay. It used to be a term in the past, but it's early childhood caries, okay? And we're going to describe the clinical manifestation and how to manage the disease. Okay, that's just a little overview of what I'm going to talk about, and we're going to start by the primary dentition. So the primary dentition, a few in numbers, okay, and if you see, the mouse doesn't work if I show here. No? Oh, yeah, it does. So the number is just telling you the pattern and the order of eruption. Okay, that's the book order of eruption. It can happen if a parent sometimes it starts at 6 months of age, but some babies will start at 4, some babies will start at 11 months. So a lot of parents will ask you this question: my child normal? Yes, there is like a little room there, but that's the book order. That's the majority of babies. They will start lower incisor and upper incisor, lateral upper incisors, and then move on. Just remember, first baby molars, baby teeth, we don't have premolars. The premolars are the bicuspids. The bicuspids later on will be replaced by the baby molars. So we have first and second molar, and we call first-year-old because it's erupt around 1 year of age, and then we call the 3-year-old molar that is around between 2.5 and 3 years of age. Okay. So as I said, there are few in numbers. The calcification of primary teeth starts during the 4th month of fetal life. So by the end of the 6th month, all baby teeth has already calcified in the uterus, okay? The first permanent molar start calcification time of birth. So imagine pregnancy to the time of birth, there's a lot going on within our dentition. So what is the key, the clinical key? Good nutrition. And not only for teeth, for overall health. That's what you guys do in anticipatory guidance every time with your patients. Remember teeth as well. We have a new pathology in dentistry now that is causing more and more research. A lot of kids this generation are coming to our office with the first molars with a severe hypoplasia. What is hypoplasia? Defective enamel. There's nothing we can do. Composites will not bond to that. So a 6-year-old child with the tooth breaking down every time they eat, and the sugar enhance that, and we have to start off with crowns on a 6-year-old child that has a first permanent molar. And now the researcher, you know, when something new comes, a lot of people comes with different ideas. As of right now, there is a little bit of relation with a high dose of vitamin D, has been a correlation. So a lot of things you eat, you drink, medication will affect the formation of and calcification of teeth. Okay, so why baby teeth are important? I don't know so much you, but I see an average of 40 patients a day, which means multiplied by 2 parents. You know what I'm talking about. So we talk, and I do restorative and also in the same time checks and health checks. And everybody says, but it's just baby teeth. It will fall out anyways, right? No, it will, but there is a reason why we were born with baby teeth. Overall health, primary loss of baby teeth cause a lot of problems in adult dentition. Okay, it will damage permanent teeth if you have a severe infection. You will have malocclusion because if you lose prior to the time of losing, the other teeth will lose the pattern of eruption. If you notice here, they have a house for everybody. All the permanent teeth are right here, and it's following the primary teeth path to come. So right around the crown of the permanent tooth, you're going to have some cells that will resorb the roots of the baby tooth until the baby tooth get wiggly, and then the permanent tooth comes. If this tooth is lost, the permanent tooth will not finish the formation of its roots. It will have some defects and will come ectopically. General health, so there is a correlation. Many studies showing that kids that have severe ECC, they are prone to have several ear and sinus infections. You can have some life-threatening condition as far as like abscesses that go to the deep fascias, and kids that affect the airway, so many admissions, many in here. When I'm on call, unfortunately, I see a lot of them. Intellectual development, they have poor speech articulation once they lose their teeth at the wrong time. They will have poor school performance. There are several research in different states. In Florida and in DC, they have different number, but overall, the data is 51 million of school year is missed due to dental pain in the United States only, okay? And also inattention. So some kids are being medicated for inattention. I had a patient recently that I did a case in a surgical center that she was almost being worked up. She was underway, 2.5 years old. They were suspecting she was autistic. Her behavior was really poor, very irritable, and she was showing some pattern of autism. And then she came for the first time to see me just because nobody sent her. And mom said, I feel her teeth are a little bit yellow. Do you think this is normal? Well, this child had something, what we call melanogenesis imperfecta. A melanogenesis imperfecta is a condition where the enamel is not formed. So it's just dentin. And the dentin is the part that hurts. So imagine all 20 teeth of that kid, 2.5-year-old, was in constant pain. We took her to the hospital. We had to do some rehabilitation, put caps and all. This child now eats well. They're still doing some testing for behavior, but she has improved tremendously. Mom says she doesn't scream anymore randomly. She doesn't show the other behavior problems she was showing before. So, yes, I don't know back in the day who removed the mouth from the body and separated our, but it should go back, right? We cannot, I wish I could remove and work on it. It would be so much easier. But our mouth is the gateway of our body. And I'm so happy, Carilion Medical School, you are part of the 25% of medical school that actually talk about dentistry. So very few. And I'm hoping to the day where we can all work and have a collaboration and study together because it's part of the body. And in social development, I'm not going to keep going. Caries teeth in early childhood, it is indicative of future dental problem in adult dentition, hands down, okay? And it will affect growth, nutrition, sleep, concentration, school, as I already mentioned. Those are quick facts. 1 in 5 kids in America goes without dental care, pretty sad. And that's not only because they don't have insurance. It's because we have lack of professionals that are trained. How many of you heard, oh, my dentist won't see kids until they're 5? Right? No. So you're not a pediatric dentist. We don't have a lot of pediatric dentists. More than 40% of children have dental cavities by the time they reach kindergarten. Okay, 40%. That's not a low number. Children with poor oral health are 3 more times likely to miss school as a result of dental pain. And of course, the cost, $2.1 billion in 2010 was spent just in emergency visits due to dental pain. So we just, here's the GPA, the kids that several studies showing that kids that experience dental pain, they have a low GPA score at school. So this is what's normal. This is what you want to see a dentalist child when first born, unless they have a natal tooth and then you call me, can you help me? Yeah, but that's the normal. A 6 to 12 months old, that's the not normal pattern, and this is a full 3-year-old child. We finish all eruption of primary teeth. So let's talk a little bit about caries and what is caries. Caries is a disease, okay? It is a chronic disease. And Sturtevant in 2002, he finally said that dental caries is defined as infectious microbial disease of teeth that results in localized dissolution, destruction of the calcified tissue. And then Fergus-Koff, he's an amazing guy. He does the majority of the fluoride studies and caries studies. As amazing and simple as it sounds to you, caries studies is one of the most difficult for us in dental school. That's what we struggle the most because it's very complex. Studying caries in the microbiology is not easy. I don't think it's too much fun either, but it's important. So dental caries is the complex multifactorial disease caused by the imbalance of physiological equilibrium between tooth, mineral, and biofilm and fluids. So it is, how many of you know that early childhood caries is the most chronic disease in early childhood in America? No? It is 5 times more prevalent than asthma. Did you know that? Largely untreated in children under 3, and even larger untreated in children under 3 for the socioeconomic status because of the insurance and the access to care. Consequences will lead to high risk. I cannot say that enough. I probably mentioned that so many times, but will lead to all those other problems I already said. and hospitalization and major emergency room visits are pretty costly. So by age of 3, the recent data it was recently published for us, by age of 3, an average of 7 to 10% of kids will have cavities in the United States. Whenever they turn 5, 60% of them will experience caries. So what is sad is it's 100% preventable. That's the thing. It's 100% preventable. So somebody, somewhere, something we're doing wrong. We need to start early. We need to start really early. And this is the perfect audience to start early. So we're going to discuss this further. I want to give you one more data that a recent article. In California, 28% of third graders have severe tooth decay. And in Washington State, their same study showed 52% of third graders. Only third graders. So, and what is etiology? How does cavity occur? It goes microbiology. Okay, it is a multifactorial. Dietary factors, host factors, modifying factors, and those are the main thing. So the main bacteria is Streptococcus mutans, and then later the Sabrinas will come to join the party and lactobacilli. They will produce an acid, and it will metabolize. This acid is metabolized by every time we consume any type of carbohydrates or sugar. Okay, so every time we eat, Streptococcus mutans, if you do have them, 98% of people have, they will start their party producing the acid lactic. The acid lactic causes the demineralization of the enamel, and then if you continue to feed them, it continues demineralization until it breaks through a cavity, all right? So the Streptococcus mutans windows of infectivity, it is when most studies have shown it is when the first primary tooth erupts. Okay, that's when you can get infected and they can start acting. Although new studies by Wen show that they're doing some studies that they were able to collect Streptococcus mutans by fissure of the tongues of babies without teeth. So food for thought here, it's a new thing. So the microbiology, the transmission may be direct or indirect, and the majority, over 70% of the transmission, we call it's a vertical transmission from mother to child. That's what we call vertical transmission. You see Jessica Alva there and all the other people. Everybody has this thing of licking the pacifier before putting it. I prefer they pick from the floor and put in their mouth. It just gives me goosebumps. I had a parent the other day. She was holding one pacifier and the other. Can I have this? Let me wash. It's done. That's it. If that mom has a cavity, it's done. The child's infected. Now for life, they're going to manage the chronic disease, right? Because you don't cure from cavities. Think like diabetes. It's chronic. You don't cure. It is chronic, and once you have the bacteria, you manage. You don't kill the bacteria from your mouth ever again. So remember that when you see your first baby when it's born, NICU and all that, Mom, let's not blow their food. Let's not take a food out of your mouth and give it to them, or lick the lollipop and give it to them. Keep it separate. Kiss their head, mouth, belly, whatever. So horizontal transmission has been largely also seen, but it's from daycare dads. We call that horizontal transmission as well. They like to kiss the baby's mouth as well. All right. So the dietary factor will most likely be what we all know, which is sugar and carbohydrates. That's what the Streptococcus mutans like, and they like to metabolize. So what is number one thing that one mom had the most wonderful question I ever had before. She said, why you guys say so much about the bottle? Why can my baby not have a bottle? Or why it's such a big deal on the open cup? Okay, there are so many factors to that question. For us, for dentistry and to prevent cavity, we don't want bottle because it is later we are going to talk about how we demineralize and remineralize teeth. If you keep the milk, the juice in your mouth so many hours of the day, you're just fueling, empowering the bacteria. So we want the baby. Also, you're going to have malocclusion if you keep the bottle in your mouth. There's so many other things. If they're laying down, they're going to start having some ear issues because then the milk will be poured down here close to a station tube and all that problems. But mainly, we don't want kids on the sippy cup because it's so convenient. Will not spread spills, right? So they put juice, and I'm so busy, so here. And then the baby will go, sit here. Oh, let's go back. I cannot move. Sorry, I'm Brazilian. I move hands and everything. I have to keep it here. All right. So they'll sip, and they'll drop it, and then they'll go play. And then they'll come back, sip again, drop it, and then they'll go play. It's wrong in all aspects. Nutrition is wrong. For your teeth, it's just wrong. And you're not teaching child a discipline of being a kid that can just sit down and eat. So I'm very stern about that, especially with my kids. Time to eat, it's time to eat. Everybody sit down. Oh, you're not done? Sorry, you cannot walk away with food in your hand. They need to learn that, and I do talk to my patients about that all the time. I hate sippy cup, unless if it's water. If you put water, then it's really good, because if that kid is sipping on water throughout the day, you know they're going to have better, not only oral health, but overall health. Okay? So, and those are just little, everything I'm talking about today, I did a big overall of our guidelines, and you can, all the references are on our website, aapd.org, American Association of Pediatric Dentistry. We have guidelines for everything, and it's open to the public. So if you have a question sometimes, you want to look it up, we have guidelines for every single subject in dentistry. Trauma, what to do with the trauma, pregnant moms, tobacco use, everything, okay? It's very nice. And today's Halloween, I forgot about it. Sticky candy is the worst form. I hate to have to say that. Everybody, what should I eat for Halloween? Nothing, but chocolate will be the choice because you can brush it off, right? Sticky candy, man, it takes 2 or 3 days, a good brusher to remove, okay? How many good brushers out there that are 3, 4, 5-year-olds? None. All right, host factor was the other factor. So dietary factor, we have the host factor, which is our saliva, our tooth, and the flow rate. So the tooth is the quality of enamel, okay, the presence of depth, the fissures of whenever you eat Oreo goldfish, you get stuck in that, hard to brush, very high caries risk rate if you see a child with deep fissures. Saliva, if you're sipping on sippy cup throughout the day with juice, soda, Mountain Dew, all that, you keep dropping the optimal pH that our saliva produces, all the phosphorus and calcium phosphate. So we have a pH of the mouth is 7. Every time you sip a soda, one sip of soda, it drops to 3. And that's perfect environment for the bacteria. And then the salivary flow rate, we need to watch that too. Kids that are on medication that will compromise the salivary flow rate, we need to consider referring them to a dentist so we can prescribe some artificial saliva and some paste, a special toothpaste, kids that go through chemotherapy, and there are so many other medications that can cause xerostomia as well. So this is so many people ask me, why this child has so many cavities, and they eat the same thing, but this doesn't, and why I do, and nobody really, everybody has this question mark, but I brush his teeth so well, and he still has cavities. So as I said in the beginning, cavities are a multifactorial. So this is our classic triad model by Keynes, that you have to have the host, you have to have the microorganism, you have to have the dietary, poor diet, all overlapping in order for you to have cavities. If you never brush your teeth, and that's very, very sad, you never brush your teeth, and you eat so much chocolate, but you never were contaminated with S. mutans, guess what? You're never going to have cavities. You can have periodontal disease, You're going to have many other problems, but you're not going to have cavity. That's why we like to start early with the pregnant moms. So talk about if they're not infected, you are setting the child for success, because even if they lack up at nighttime when you send them to brush teeth and they just wet their toothbrush, put aside, they're still not going to have cavities. But then we have the modifying factors, and we keep studying, and now we have the race, ethnicity, socioeconomic status, the healthcare system, genetic factors, all this are playing a role. And then Newburn in 1982 developed our new model. And then the new model is all that will affect a child having a cavity or not. And I'm not going to go in depth. This is a very, very complex. But just keep in mind that we have to have at least 3 in order for us to have a cavity. And that's another very sad stat, that dental caries is the most prevalent unmet healthcare need for a special child. It is really sad, and that's not only because of, once again, I cannot say this enough, because of insurance and access to care. That's a major factor, but also is the fact that we don't have a lot of personnel trained to deal with this kid. So a lot of patients will come to me and they say, oh, I've been to 5 different dentists. Nobody wants to touch a child that has heart condition. I just saw Dr. Doherty walking in, and there's so many conditions and syndromes that a lot of dentists will say, oh, I don't want to touch it. They look like a ticking bomb for a lot of people. So that's why when we go to pediatric dentistry, we, in residency, we learn how to proper care. So we don't have enough, and we don't have enough pediatric dentists working in hospitals. There's another problem. A lot of these kids cannot be seen in regular clinical settings. Today, if I have a special need walking in my clinic and they need to do any intervention, my waiting list for Roanoke Memorial is 12 months. By 12 months, so it's very frustrating, but it's just me and Dr. Jones, 2 of us for the entire valley. People come everywhere because we have access to the hospital. At least we have access to the hospital. We can do. A lot of those kids go a long time without dental care. That's why we need to start early, because we can prevent, right? So let's talk about early childhood caries a little more. So if you look at a child like this, you don't think anything of it, right? But a lot of people don't, especially the parents. But she's already on the severe stage of the disease. All the white spot, heavy plaque, this is already broken. This is all cavity on the way. Whenever you see black, means the bacteria already died and the cavity is arrested. So black cavity, to my eyes, they are over the hump of the disease. When you see white and light color yellow, is the most infected, and bacteremia in the mouth is happening, okay? It progressed very, very fast. And why is that? Primary teeth has a different anatomy, as we said. It's a thinner enamel. So a cavity, once they acquire the first stage of demyelinization, it takes about 6 months to break through the dentin if we don't do anything about it. Adults, the enamel thickness of the adult dentition is 3.5 millimeters. So adult can go with a white spot lesion through 3 years without having a cavity, and babies can't, all right? Those are my 2 cases last week. The first case here, he is a 23-month-old child that was in the NICU for about 7 months, failure to thrive. Was G-tube fed for a while, and he didn't even have all his primary teeth erupted yet. And this, if you could feel, is so demineralized that it feels like a jelly once you touch. And then this parent came to my office and he said, well, I don't know what else to do. This child is not eating, and I'm afraid he's going to have to put a G-tube again because he's failing to thrive. Well, he can eat. This pain is horrible. It's a horrible pain. I'm not going to ask this question because it's embarrassing. Maybe you never had a cavity. Maybe you did. If you did, it was very small, and you eat like a piece of sugar, and it gives that sharp pain. Maybe you never had that, but that's the pain. Imagine throughout a mouth of a child that cannot even say, my mouth hurts. This child here is also, he's already 24 months. And the reason it's black is because he came to me like this. He had to wait 3 months to go to the hospital. And I placed something called silver diamine fluoride, silver nitrate mixture with fluoride, and it will arrest the decay until I can actually see and diminish, and it completely cuts the sensitivity. So I've been doing a lot of that with my patients that have to wait. A lot of parents will not let me do it because they don't want a kid to go with the black teeth, even if I explain this will, subside the pain. It's just temporary. It's an interim treatment. I cannot see him within the next 3 months, and he can eat better. They still say, oh, I don't want a black tooth. But it's understandable. It's socially not accepted, but it's frustrating sometimes, okay? This, you know how costly this is. Every time you take a child to the operating room, is at least $25,000 to the insurance. With all the operating room, the dental, not all the dental, unfortunately, but it is a very high cost for us to take a child that is not even 2-year-old. We don't need that. It's 100% preventable. I'm going to keep saying that. Okay? And what is the next stage of this? You'd have abscesses, and those abscesses can be life-threatening at some point. And in some kids with some conditions, they can have bacteria in the mouth like that. Our heart kids cannot have. A lot of other syndromes they cannot have, right? This is a little more other patient picture. I'm sorry for the poor quality of the picture. I don't know what happened. So this is another recent fact as well. The Candida albicans has a very strong correlation with the caries. And the main reason is because Streptococcus mutans is early childhood caries. Streptococcus mutans like the Candida albicans. So essentially, Candida will use the acid produced by the Strep mutants as an energy source. And the Strep mutants use the Candida as well. So this is a child that was admitted, and she had to be admitted for 3 days, severely dehydrated, and she had severe early childhood caries. And you see this all the time, right? The blue, I don't know where the blue, I think the blue is from the Gatorade. But under the blue is just a very thick, the Candida, and then plaque. She had plaque on her teeth. I don't even know how she could eat, and that's why she was admitted. She was very dehydrated. So we need to keep in mind that as well. Every time you see a kid with severe thrush, or when you see the fungus, let's take a look at the teeth, and let's send a referral to the dentist, because she'll be prone to have it again if we don't treat the teeth, okay? So once again, this is an abscess, and this child had 5 of those. This is a 2.5-year-old, also lost all the teeth. We were able to save the canine, this one. And this child is 3. So they're going to go to kindergarten, and their peers will have teeth. This child will not have teeth, okay? So psychologically, it does number their little mind, okay? So what you have to do with all that, everything, you health, non-dental primary health care providers are positioned in a very unique spot where you're the front line of our battle. They're going to see you first before anybody else because they do have the very short well visits in the beginning of their first life. And as you could see, in 1 year, there's so much you can do. So much you can do. A lot of dentists will not see the child under 3. If you do have a pediatric dentist in town, they will. So a lot of patients will say, I went to the pediatric dentist, they said they don't see a child under 5. I said, well, they're not a pediatric dentist because I only see under 5. So make sure you find, if you can go to APD website, you can type a zip code and it will pop up the name of all providers because you can start referral this early. We can start treating those child and hopefully we can get to, a lot of people, you keep saying that, I worry about not having patients anymore. No, I like to do education. That's also part of our job. I don't need to be doing surgical treatment all the time, and I don't want to. I like the educational part, okay? So you're in the best position, and prevention is the key. Early oral exam or early risk assessment, anticipatory guidance, it will help this kids a lot. Early identification and management, we can do this, okay? That's the rationale. So when they come first to you, what are you going to do first? You're going to determine the risk assessment and provide family education. You're going to look at the environment of the family. You're going to look if the package is mom's mouth. You're going to look at the mom's dentition. She's going to smile. You're going to see right away if they have a good oral health or not. And you're going to start talking to them about it at that point. Recognize the disease early. If you start recognizing once it's just the first stage of demineralization, we can reverse the process without having to do surgical intervention. So that's the beauty of the enamel. You can repair enamel if it's still early, but you have to be able to identify, right? Because parents will say, she didn't have anything and all of a sudden it's all broken. No, she had a lot for at least a year. Now you can see. But before, the white lines, nobody cares. Nobody worry about the white lines because they're white. So they don't think it's cavities, right? And then you can do the fluoride management, which we are already doing, and I love it. Thank you so much. And establish the dental home by 12 months of age. So that's the new guidelines. They do have to establish their dental home by first tooth eruption, or it's 1-1, first eruption or first year of age. So the caries risk assessment, we're going to balance the risk factors with the protective factors. So you're going to look at the child. You're going to see visible caries. That's a risk factor. You're going to see poor saliva, another risk factor. You're going to see, oh, they come in drinking Mountain Dew in the bottle, and this is not a made-up story. I did have a baby with a Mountain Dew in the bottle when I was in Florida. You're going to see the anatomy of the teeth and the very deep fissures, and then you're going to balance with the protective factors. Bless you. You're going to ask, do you have fluoride water? Do you brush with fluoride, or you brush with herbal whatever gel you have? So you're going to balance those, and then you're going to determine if they're high. I'm sorry. Determine the risk factors, and then individualize the treatment plan for each child, okay? So how you're going to recognize early. So the white line you see, usually the decalcification is going to start right where the attached gingiva is, the sulcus, because it's where the liquid and the juices and the sugar will pool and will sit right there. So that is a decalcification line. That's the stage 1 of cavities. Can we reverse that? Yes, we can reverse that. Adequate fluoride varnish, start good oral hygiene, cut the juices. That's usually, if you see cavities on the facial surface of the tooth, it's from liquids. If you see a lot of interproximal caries, are from pastries, goldfish, Oreos, like things that they'll eat and will just go in between and stay there, okay? So this child, this part here, we can reverse But you see right here, there's a cavitation. That we can reverse anymore. We cannot. We can do silver diamine fluoride and not do a restorative because as you can see, this baby's probably 15 months old by the dentition, doesn't have the canines yet. So we don't need to send this baby to the hospital because of this cavity. We can go ahead and do a little arrestment of the decay, wait until they're old enough, and then we can do some restorative in the future, okay? So the demineralization and the white spot, it's a constant, our mouth is a constant demineralization, remineralization, demineralization, remineralization. So you drink the soda, the Mountain Dew, and the pH drop. But then you can drink water, and then you give a rest to your mouth about 3 hours. Your salivary flow will come back with a lot of calcium, phosphate, good minerals, and there will be a buffer for the enamel. But then you drink again, and then you have a snack, and then you keep dropping. So it's a constant balance. But if you can talk to the parents about school lunch, give water, that will help. Wait 3 hours until you feed your child again. Or between meals, let's use what we call detergent foods. Cheese sticks, very good. Grapes, very good. Carrots, apples, all those are foods that will produce salivation. It has a good consistency and will help remove the plaque from the teeth, okay? And then we talk about this. And what are the topics of anticipatory guidance? When you first see an infant, we're going to talk about fluoride and xylitol with the moms, the pregnant moms. It has so many studies showing the moms that chew xylitol gum, they're least likely to transmit the strep mutans to the child. So what is xylitol? Do you know what xylitol is? We'll talk it in just a little bit. So we're going to do home-based fluoride topical application. We're going to do dietary counseling. We're going to talk about oral habits. Those are the topics I talk every first appointment with my patient, and we go in depth with one by one dental injury prevention and the developmental changes that will occur throughout the life. And that's my second child. The protective factors will be oral hygiene, dietary habits. Remember, we talk about the caries risk assessment. Those are the protective factors. If the child has good oral hygiene, good dietary habits, early intervention, a dental home, all this, you will determine the caries risk of the child based on their protective factors, okay? And what is the best practice? We're going to brush twice a day. And this picture here is showing a child between under 2 years old. It's just a smear of toothpaste. And then after 3, it's a pea size. Why is that? We don't want them swallowing, correct? And why swallowing fluoride is not good for you? The risk of fluorosis. Do you know what fluorosis is? Fluorosis is when the permanent dentition that is underway in calcification get oversaturated with fluoride, and then our enamel, they are formed in very perfect crystal lines, and then they all go in one direction to form the enamel. Whenever it gets oversaturated with the fluoride, that lineup of crystals will get a little bit disturbed, and you're going to see white lines of scars on the permanent dentition. So some fluoroses are so intense that the lines are not even white or like dark brown. And you cannot remove that. It is the quality of the enamel. The only way to treat is actually to doing veneers and caps and things like that. So it's very aggressive. We need to be careful with that, okay? I recommend my patients to not rinse after brushing. So mouthwash has exactly the same amount of fluoride in a toothpaste, okay? So you brush your teeth, you rinse your mouth, and then you rinse your mouth with mouthwash. Well, I do the opposite. Rinse your mouth with water first. Remove gross debris of food. Brush your teeth. Spit out the toothpaste. That's it. You did your mouthwash right there. It's the same amount. You have to leave it in your mouth. You cannot rinse after. Fluoride and water, water cancels out fluoride activity. So that's why we say do not drink water after fluoride for at least 30 minutes. It's the time that the fluoride has to penetrate the tooth surface. So for a child that is running around so difficult, just lay them down on the couch on their changing table, brush the teeth with a washcloth, wipe off the remaining of the foam or the toothpaste, and let them go. Don't give water for at least 30 minutes, okay? That's a stock picture, was so famous on the internet for a long time. And he was so proud. He said, I think it's Drew, the name of the baby, said Drew is on the do also. Yeah, so the dietary factor will play a huge role. And as I said, I thought it was fun because I did have a baby with the Mountain Dew. And then they complain, but Dr. Miller, they also cannot sleep. They don't sleep well. They don't eat well. Of course. Give me like Mountain Dew. Do you want that Mountain Dew child to sleep well? Probably not. So many little things we change. They're so simple. We change the quality of the life tremendously, right? So high frequency of sugar, we all know that. Nighttime feeding is one of the worst because we don't produce as much saliva at night, so we don't have our buffering system working, okay? And then CP cupping between the meals, it's also bad, and we talk about, I'm getting ahead of myself. I want to try to move forward here. So the oral recommendation remains that, do we all know that the CDC finally issued no juices under 1, right? But the only thing I feel sad about it, they only mention obesity. They don't mention our number 1 problem we have right now. Thank goodness obesity is not our number 1 problem, but caries is, and it's been costing a lot of money to the government. And the CDC issued this beautiful thing, which I love, but they don't mention the problem of cavities. It's just because of obesity. But you know what? We'll take that for now. And oral habits, a lot of you guys call me asking those simple questions. That's why I put here, when should we stop passy? By age of 2 to prevent malocclusion, okay? When should we start cleaning the baby mouth at birth? Washcloth, like I said in the beginning, they already found strep mutans in the fissures of the tongue. So after feeding, just wet a washcloth and wipe off the baby's mouth, okay? And the fluoride mechanism of action, I kind of said it a little bit. Fluoride is also a mineral. The topical, it is the most important. So don't worry about prescribing fluoride. The topical application, it is what is the most important effect. All research shows that it is the one that will promote the higher remineralization of the tooth, okay? Fluoride also has antibacterial effect. It will disrupt the enzyme system, and it will alter the plaque composition of the biofilm. Systemic, there's not a lot of studies showing that it's very effective, especially because today we have fluoride not only, some people are being well water, and then we worry about it, especially if they're already very high caries risk. But if they drink milk, if they drink grape juice, if they do formula, all those have fluoride. So if they establish a dental home with some of these products, they may not need a fluoride prescription because we do want to avoid fluorosis in kids, okay? So this is a little table. It's all over the internet. So whenever you try to prescribe fluoride, I'm sure you guys know that because you prescribe. And that's the guidelines recommended. There's no recommendation for prenatal. There's only one randomized controlled trial. It shows the grade of evidence is just 1, and it shows no benefit to the baby at all. So we don't want pregnant moms taking fluoride and their prenatal vitamins. And then for the children under 6 years of age, it's still recommended to prescribe, but you have to do a very thorough risk assessment to make sure the child really needs it, okay? And that's the recommended doses. The fluoride varnish, what you guys doing? It is a 5% fluoride. We're going to do in a very small amount, and it is not effective. It does not stick on the tooth. So you have to have the tooth surface dry before apply. Lay a child on your lap, dry the tooth surface with a gauze. As you are drying with one finger, you apply with the other. Because if it clumps up, right? It clumps up and it starts falling pieces. If it does not stuck in the tooth, it's not going to be effective, okay? And that's the beauty of the varnish, so kids will not swallow. As soon as it touch the mucosa, we'll stick in the mucosa so they don't have the ability to swallow the fluoride. All right, and this is how I do all my infant oral health treatment. Well, I have a board. My board is not there right now. But that's the best way for you to do an oral exam is knee to knee. You sit, the mom is holding, so the child is not traumatized. They know the mom is part of the exam. And then you can have a better overview of the mouth that way. And that's how I apply fluoride varnish as well. So I talk to mom first, do all the anticipatory guidance. I do all the talking before. By the time we lay down and they start singing and yelling, their mouth is open. That's perfect. You do your exam, you do your fluoride, and then mom, she's not paying attention at you at that point anymore because the child's crying. So do all the talking before, and you're more well-versed of that than me. So what is xylitol? It is a carbon sugar alcohol, okay? And it looks and tastes. It is a plant. And we found that it tastes really good, and strep mutants don't like it. They actually die if they try to process this sugar. So we start seeing very strong evidence. We did a lot of studies that now people that chew gum with xylitol actually diminish the amount of bacteria in your mouth. And then you don't transmit to the child, okay? So Trident, Orbit, Mentos, all this now comes with xylitol. If you look in the package, if the first ingredient is xylitol, you're good. Although they don't have the amount necessary to actually kill the bacteria, but helps you producing saliva, and helps a little bit. But if you really want to attack the bacteria, you should order online only the higher grams of xylitol. They have gummies, they have lollipops, they have chewing gums. And some moms are now even cooking with xylitol sugar, cookies and cake and baked goods with that, okay? The silver diamine fluoride is the silver nitrate. It was only approved in the United States in the year of 2014. I was still in my residency when they approved, but it's worldwide used. Oral Health Organization, we use to arrest the caries of when you go to missions and places that you cannot give appropriate care. We use silver diamine. So keep that in mind if you have a patient with in pain. We can provide that because a lot of patients will complain they're waiting so much to see us. And the reason they're waiting is not because we are just sitting down not wanting to see patients. It's because we have a lot of patients and there's not a lot of providers that will see this type of population, okay? So the silver diamine, we will arrest the decay like this. And then whenever I do restorative, I can remove everything and then we can, it can be aesthetically with the final restoration again. So we're going to talk about dental injuries as well when you do your anticipatory guidance. Car seat, which you guys do a wonderful job, but one thing I want to mention, anybody here with emergency room, work in the emergency room? Do you see this picture here? It's a molar fracture. Chin trauma usually will cause molar vertical fracture. A lot of the times the child goes to the ER with a chin trauma. Nobody looks in the mouth. And then 20, 30 days later, the child has an abscess. And then they come, that's it. So make a quick survey. A child fell, look. If you don't see anything, I would still recommend see a dentist for x-ray. So every baby that falls with the chin, I always do x-rays on the molars, okay? So this is talking about the pregnant moms, the new moms, how we can do the xylitol chewing gum to provide anticipatory guidance for them. And that's our referral. 1 tooth, 1 year of age, they should start seeing a dentist so we can establish a dental home and start prevention care. Okay? So we are running out of time. I was going to talk about antibiotics when it's needed. You know, this was a referral to me. A baby was on 2 courses of antibiotics and then through the physician, but it was just an eruption cyst. It was not. So if you see this in the mouth and you pair with the age of a child, eruption cyst is very common, and we don't do anything about other than just chewing toys, giving some popsicles, some cold. Okay, we obviously don't give antibiotics for that. All right, and the teen moms, extremely high caries risk because she's at risk herself. So we need to provide anticipatory guidance as well, and you can refer her to the dentist as well. Okay. And this is my last slide. That's a child that was she's a foster child, was being teased. The black is because I put silver diamine. She couldn't eat. She was not eating but applesauce. So I put silver diamine. She had to wait. We were able to expedite her, but she had to wait at least 4 weeks to be seen in the OR. I removed every single tooth. I was able to save the lower ones, and we were able to provide a little denture for her, and it made her life way better. So she wants to be a dentist, and she comes every time, brings me stuff and hugs, and she wants to work with me because it really changed her life. And she's doing foster care, soon to be adopted. All right, go Gators. Any questions? Yeah.
Dental health for pregnant women. I see, and probably other folks see, moms with newborns that they have had trouble with their teeth during their pregnancy, loss of.
Yeah, that's a wonderful question. Absolutely, we should counsel our pregnant moms to seek care. There is this saying that it's not safe. What is not safe is for the mom to have an abscess or a periodontal disease because it will lead to a premature delivery. So they definitely need to be seeing a dentist periodically during pregnancy, and if there's any dental issue or especially periodontal issues, which is the gums, moms snacks a lot more, right? The pregnant moms, and they'll be prone to have more periodontal issue. And there are some articles out there showing the bacteria in the periodontal tissues related to premature birth. So definitely they need to seek care, refer to the dentist, and make sure their dental care needs are met. Is that kind of what you wanted to know? Because some people say it's not safe because of the local, because of this, but we have so many advanced medications today. It is safer for us to actually treat her than the consequences of the disease in her body, okay?